All right, welcome everyone. My name is Linda Wiley, and I serve as the Director of Online Learning here at ACUHO-I. And I'm very excited to be with you today to be discussing a very timely and important topic for our campus communities. The title of this webinar, as you see, Campus Readiness for Measles, What Health and Housing Leaders Need to Know. This is an exciting partnership between ACUHO-I and the American College Health Association, ACHA. I want to give a special thank you to Robin Boxbaum. Robin has been a great partner in previous programs that our organizations have done together, but in this one in particular, helping secure really top professionals to speak on this topic. So thank you to Robin. Before we move into the presentation, we will be utilizing the Q&A feature in Zoom. So if you look at your bar across the bottom, there is the chat, but there is also the Q&A function. We will have time toward the end of the presentation to answer questions as they come in. For those of you that have the Student Affairs certification, I will be putting the CE request link in the chat near the end of the program. So I'm going to do an introduction of our panelists, but they will then also share with you a little bit about themselves and their work when they speak. We have with us Dr. Albert Chang, who is the medical director at the University of California-Irvine. We have Emily Lenz, who is the Director of Health Services and Nurse Practitioner at the School of Art Institute of Chicago. We have Dr. Jeff Novak, who is the Associate Vice Chancellor for University Housing and Dining at the University of Wisconsin-Madison. We have Ron Thompson, who is the Associate Dean of Students and Director of Housing and Residence Life at Furman University. And we have Stephen Woods, who is the Program Director for Campus Health at Yale University. So with that, I'm going to turn it over to Dr. Chang.
Thank you so much, Linda. And I feel both honored and privileged to be starting as first speaker for this presentation with my esteemed colleagues. We've got a great team here. So as Linda mentioned, I'm the medical director here at the UC Irvine campus in Southern California. I'm a pediatrician by training, and I kind of crossed over to the dark side and came to student health leadership about 9 years ago. And it's a population I've fallen in love with, and probably you all are, it's a love-hate relationship, right? But it's a population of these older kind of population that I'm used to, but young adults, an opportunity to really impact their lives and their health moving forward. I've seen on a personal level, I've seen 2 cases of measles in my career. The first was as a second-year resident at the Children's Hospital of Orange County. It was an 18-month-old a patient from Mexico that did not have access to vaccinations, hospitalized, luckily did okay, but just his suffering, it'll never kind of leave my mind. And then the second case I saw was about 5 years ago on our college campus with a graduate student. And actually health and well-being was much better, but it opened our eyes to the true risk. This was right before COVID. And so it prepared us for outbreaks. And so my goal here today as one of the clinicians here is to speak about the basics. So, and we'll go ahead and start. So next slide, please. So why does it really matter on our college campuses? Well, it's really the contagion of measles as an airborne transmission. We here at the UC system have 4 vaccines that are required and mandated for our student population, and measles being one of them. And the main reason is for its transmission. On our college campuses, you all know this. So our housing environment, it's unique, it's high density, it's concentrated. So the spread of infection, really, we're a hot spot. But in addition to housing and residences, our classrooms, our dining halls, our recreation areas, this is a population that gathers frequently and travels. We have a huge international student population here, and so they're traveling back to their home countries where public health measures and vaccine rates may not be as stringent as ours, and they're coming back into our population here. And then just the population, young, adults, individuals, and invincible in some ways, they don't always seek medical care when they should. So we may not be pulling them in. So identifying these cases, spreading information, vaccination, and control otherwise. Quick number here is, one case can expose hundreds of people in a single day. It's one of the infections like tuberculosis. And when I was back in med school, the statement was, well, if there's one person with measles in a movie theater and they cough, everyone's exposed, and it just spreads that quickly. Next slide, please. So very quickly, measles, also called rubeola virus, highly contagious, spread through respiratory droplets and aerosolized particles. That's why it can spread so quickly. And it can remain suspended in the air for up to 2 hours. So even though there may have someone that came into the library or into the dining hall 2 hours ago, it's still potential. There's a number that's called R naught. That's kind of that infectious rate. And just in comparison, influenza has an R naught of around 1 to 2, meaning that one person will infect in a susceptible population 2 other individuals. COVID is kind of 2 to 3. Measles is 12 to 18. So that's just such a high number. And so one person can truly infect 12 to 18 others in a susceptible population in a short amount of time. Next slide. So this is some of the stuff that most of us are familiar with, but because we haven't seen it as much for decades, just a reminder. The symptoms in the clinical course. So the incubation period, it's about 1 to 2 weeks from your day of exposure. And it starts off as any kind of cold with fever, cough, and a runny nose. The red eyes of measles is pretty commonly seen, and fatigue and weakness, like you'll see in other infections. So you may not know it's measles right off the spot. Some of the more classic findings, there are these rashes inside the mouth called Koplik spots. And I've got a few pictures to show that are pretty indicative of measles. But other things can cause spots inside the mouth, cold sores, things like that. And then what we all know is the red macular papular rash. And that's the red bumpy rash that kind of starts on the head and spreads downward that we all know about with measles. Some of the complications from measles infection is they can lead to pneumonias through the pulmonary system, and then more seriously, encephalitis, which is infection and swelling of the brain, and then hospitalization, and in worst cases, fatality. Next slide, please. Okay, we're going kind of old school. So this is the first picture, cough and cold, right? So just basic body aches and symptoms. Next slide. So these are those red eyes, so deeply red, irritated, and painful, usually both. Next slide. So these are those Koplik spots. So white spots, small spots inside the cheeks, inside the mouth. Next slide. So this is an example you can kind of see on the cheeks and the forehead here. We call it a confluent erythematous macular papular rash. So it's bumpy. You don't always see like the vesicles that you get with chickenpox. And then next slide. And it has this progression from the head down. So cephalocaudal is like the technical term. And I remember back in med school when I was, studying for all this stuff, they called it like pouring a bucket of red paint on your head. And it kind of progresses down from your forehead to your face, to your cheeks, and then over your neck and your shoulders. And that's kind of represented here. Next slide. Okay, so one devastating but rare impact of measles infection is called subacute sclerosing panencephalitis, or SSPE. You may be seeing articles on this. There was a case, unfortunately, last year in a school-age child here in Southern California, Los Angeles. So this is rare progressive degenerative brain disease that occurs years after the initial measles infection. So the patient that passed away here in Southern California actually was infected when she was under 1 year of age, when she was even too young to receive the vaccination, and it came up and impacted her as a child in school. So it's a mutated virus that kind of remains in the brain over time, and there's severe neurologic deterioration. So this typically happens 6 to 10 years after the initial infection. It might start very simply with some behavioral personality changes and then memory loss. So like more neurologic stuff, and then seizures and muscular jerks. And in the later levels, there's a severe cognitive decline with loss of motor function, with coma and death, and almost always fatal. So the good news is that this is very rare and very uncommon. The bad news is with the increased number of rates that we're seeing, it's definitely going to be seen more commonly. So just to be aware of, once again, it's rare, but it's devastating when it does happen. Next slide. So when is measles contagious? Just some of those basic numbers. It's 4 days before the rash even appears. So you might think you have the flu or a cold, and then it's still infectious for 4 days after the rash just kind of started. So that means that students may be attending class, maybe eating in the dining halls, participating in events, traveling across campus before anyone really even suspects measles infection. So the big important message here is if you're feeling sick, if you've got symptoms, stay home. Don't go out. Try not to go to work if you don't have to, because you don't know what you might be spreading. Next slide. And then why are we seeing this again? So just global and national trends. Disruption in the vaccinations. I think that's probably the main reason. And the reasons for that through vaccine hesitancy and misinformation. We're just seeing these declining rates kind of across the board. And then when coverage falls below 95%, that's that magic number where herd immunity weakens. And so infection spreads more quickly and outbreaks increase across the board. And once again, for us as campuses with multiple people converging and gathering at sites, we can become an amplification site for this infection. Next slide. I'll wrap up there and pass it over to Emily.
Good morning, everyone. I'm Emily Lenz. I am a nurse practitioner and the Director of Health Services at the School of the Art Institute of Chicago. Next slide, please. So I'm going to talk about how student health centers can prep and develop processes to help prevent measles and deal with cases if they come up. So through 4 ways: immunization tracking, an exemption process and tracking, vaccine clinics, and pre-planning with public health. Next slide, please. So immunization tracking, it's critical to maintain and ensure timely access to documentation of measles immunity status for all students. I know some states this is more difficult than others in terms of rules around what you can collect from students. I'm lucky to be in Illinois where we have state laws that require vaccines, and MMR vaccine is one of them that we require. So we have all that information. I shouldn't say all. We have the information for most of our students. They do get a 1 semester grace period, and so that comes into play sometimes. It's also important to communicate to faculty and staff the importance of obtaining documentation of their measles immunity if they were born after 1957, as this will be needed if there is a case on campus. So you can collect that data from your faculty and staff as well. State immunization registries can be very helpful and can be integrated with many EHRs. We have an integration between Medicat and our state registry. And recently, it's not an integration and not an automatic thing, but students can request their records from other states as well to come directly into Medicat, which is super helpful in getting this information. Next slide, please. For exemption processes and tracking, apply consistent evidence-informed exemption processes. This also will probably depend on your state law somewhat. Track those with exemptions to measles vaccines and other things too. I just keep a spreadsheet. We're a fairly small population, but just somehow so you can either run a report or get information about who does have an exemption, because these students may need to be offered either vaccination or other post-exposure prophylaxis to prevent infection and serious illness after exposure. And these students will often be excluded from campus in the event of a case or an outbreak. Next slide, please. Vaccine clinics. So the best way to prevent the spread of measles is to ensure all students and staff are vaccinated or immune to measles. If you can, provide MMR vaccines to your campus community, either as your student health center or by partnering with your local health department or local vaccination providers like pharmacies to set up vaccination clinics on campus. And if it's possible, make MMR vaccination accessible for those who wish to receive it. It's the best way to prevent measles. Next slide, please. And then pre-planning with public health. So know how to contact your local health department. Ideally, have a point of contact ahead of time. Discuss plans for how to respond to a measles case. This might be a tabletop exercise, something like that. We did something like this in like 2019 prior to COVID, which was super helpful because then we had our contacts there to help us out for that as well. Align your campus procedures with the current health department guidance and regulations. This could be at your local or state level or the national level, and keep your emergency operations plans current. And now I will pass it over to Stephen, I believe.
Great. Thank you, Emily. Thank you, everybody. It's Stephen Woods. I'm the program director for campus health here at Yale University. Formerly was the associate director for emergency management for Yale University. So I was with emergency management all through COVID, and campus health was stood up as a new department after COVID. And so in my role here as program director, I help oversee the student health compliance program. So all vaccine compliance comes through my department, as well as some of the other health requirements in addition to vaccines. And I also help oversee the high impact infectious disease program and planning here at the university. Next slide. So in setting the stage, and again, we all know this, when a single case of measles is identified on a college campus, the transition from business as usual to a public health event happens instantly. And because of the high transmissibility and the density of student housing, coupled with overall academic, social, and work settings, a successful incident response is never a solo effort. Managing an outbreak, even a single case, requires a seamless pre-established network of collaborators where strong partnerships are the bedrock of the public health response. Next. So in addition to the clinical care, there are also a number of other questions to be answered at the university at the school level. For this kind of example, we're going to kind of assume it's an undergraduate student or with a single case. But if it were an employee or a family member, some of the questions are the same. Some of the consequences and risks are a little bit different. So I look at housing. The questions you want to ask is, so where does the student live? Do they live in a dorm? Do they live in an apartment, a suite? Do they have a shared bathroom? Do they have family members that they live with? Are they commuters? For isolation and quarantine, the questions are, what are your options? Can you isolate or quarantine in the dorms? Do they have a private bathroom? Do they have roommates? How about sending students home? Is that an option? And what would that look like? For dining, students in isolation quarantine, how will they get food? How will they get fed? During COVID, we looked at a whole host of different options, from delivery to food boxes to prepackaged. Some work better than others, but in the measles case, not all options can be used because of the transmissibility and infectiousness. Custodial services. So what are the additional cleaning requirements of a space, of buildings, of residential halls that need to take place? And what are also some of the other considerations for the custodial staff who will be asked to clean those spaces? Public safety, what do they need to know in the event of an emergency? What do students in isolation housing need to know if there's an emergency? And we also saw this during COVID. We had a separate isolation dorm, but as throughout the year, there were fire alarms. So we had to have specific instructions for what the students who were in isolation or quarantine in that building could do in the event of a fire alarm. We also had to let public safety know what they could do, what to expect when they were responding to address and investigate a fire alarm. And academic support. When you have students in quarantine and or isolation for an extended period of time, especially toward the end of the year, academic support is going to be very important. How are these students going to be able to continue their study? Is there a plan for remote learning? Is there a plan for addressing any kind of academic accommodations that may be needed? And then communications. Who needs to know what? And who needs to be responsible for sharing that information? So internally, there's obviously the Health Services Center needs communication within their staff. Emergency management needs information. The student life team needs information. So what information do you think you're going to need to share, and who's going to be responsible for sharing it? And externally, who's going to communicate with parents, who's going to communicate with public health and/or state and local agencies. And then finally, looking at the incident command and incident coordination. Who's going to take the overall responsibility at your institution if there is a case or a couple of cases? Is that health services? Is that the Office of Emergency Management, Public Safety? Is it the health center? I'm sure you have a lot of other questions, which is good because the questions are the backbone for your planning. In this situation, you always want to continue to ask yourself, what if? Next slide, please. So knowing the questions to ask is the start. Knowing who is responsible for each question is critical. Here's where you can start to build your own department planning team. Look internally to start with. Ask each question and identify who can help answer for you. It may be another department, but it's your planning team, and these are the people that you will need to work with. If there's an existing emergency planning team at your institution, make sure that health services and the housing office are part of that team as well. Next slide, please. You also want to find out if there is any current infectious disease planning going on. Here at the Yale Health Center, we've been actively planning for what we call our high impact infectious diseases. Our initial focus is on the health plan response. How will we respond internally as a health agency? And then we'll be expanding out to the greater campus, involving the other departments as necessary, housing, dining, etc. But you also want to know who's taking the lead in there, again, in that response. Is it health services? Are you going to be expected to take the lead? Is it emergency management? Knowing who the lead is really important so that you can avoid miscommunication or cross communications. Also, don't assume that somebody else already has a plan. Find out the details and review their plans with them, and ensure that their plans are your plans. Health services may think it's safe to release a student back to isolate in their rooms, but dining may not have a plan to actually provide feeding for that student while in isolation. So work through that ahead of time so you're not caught off guard at the time. Next slide, please. Also want to learn about the incident command structure at your university. Learn about who is going to be in charge, who is going to take the lead, who will serve as the overall incident commander. So you're going to want to know, where does your department, whether it's housing, health, facilities, etc., where does that fit into the larger response? And who will you be taking direction from? Who will be calling the shots at the university level, at the department level, etc.? And then what information or directions are expected of you? If you're the housing department, what is it you're going to need to provide to the incident commander about the services that you can provide students? If you're the health center, what information are you going to be able to provide or not provide regarding clinical care or assistance with the student health? Next slide, please. And finally, it's important to have a written plan. And the quote is, hope is not a plan. So having written plans is critical for each of the operational pieces and each of the questions that you've had. Don't wait for others to come to you and ask questions, but be proactive and reach out for them. You also need to make sure that you're not planning in a vacuum. You need to align with other departments. Isolation and quarantine, as an example, is probably one of the most complex considerations and requires a clear pre-planning and robust coordination. All the pieces need to fit together: housing, health, facilities, dining, the works. They all have to work together for this plan to work successfully. So work with your emergency management team to schedule a tabletop exercise. Once you have some of your plans in place and you've reviewed other plans, that's the perfect time for a tabletop exercise to put them all on the table and review. Start with a small scenario. Don't start with a 10 or 15 person outbreak, but maybe it's a single student that's approach to your health plan for testing for possible measles. So put that as your scenario, put that on the table with the group, talk through what each group would do, all the considerations. When you think you're comfortable at that scenario, then you can elevate it a little bit. Maybe the student was on the wrestling team. What does that look like? What is that going to add to the response? And then eventually you're going to want to reevaluate and retest, reschedule a tabletop exercise again to retest it. You also want to make sure you review as a group and to share all of this information internally with all of your team as appropriate. Everybody needs to know what the plan is, both within your group and at the larger side of the university. Next slide, please. So that was it for me. I'll turn it back to...
I think it's coming to me. So thank you so much, Stephen. Thanks to the three of you. This was really important information, and we're now ready to move from some information sharing really into what happens if and when you have an outbreak or a reported case on your campus. So with that, we already have a couple of questions that I know we are going to cover, but I do want to highlight those. But the first being every person that registered will receive a link to the video recording of this webinar as well as the slide deck. So you will all receive that. It will be housed on the ACUHO-I YouTube channel. And so you will all receive that. And we encourage you to spread this far and wide with your colleagues. The two questions, and because the team here prepped beforehand, I know we will cover this, but one of those questions from Brian, my understanding is that unlike COVID, measles can spread through air ducts and HVAC. What are recommendations for safe measles isolation in housing? So we will get to that. The other is, what are some ways campuses have engaged employees to ensure that they are vaccinated? So we will touch on that one as well. So the first question is going to go to Jeff and Ron, then with the rest of the team chiming in. Walk us through those first few hours of a reported case, if you will. What happens, who gets notified, and what is really the most time-sensitive decision that needs to occur?
Good afternoon. I'm Ron Thompson. And, I think for starters, I'll just acknowledge that those first moments really depend on where that initial notification comes from. It's generally assumed that it'll come from the student health area. But I want to remind everyone that our universities are vast, diverse systems, and we understand that students don't always go through student health services to address their health issues. Sometimes they go through urgent care locations off campus, family health clinics, and sometimes they may even self-diagnose. Sometimes they tell friends, roommates, or faculty members. And we've seen that just as we did during COVID-19, that we can't always count on students to notify our student health center immediately. Ensuring all employees know who to communicate with immediately should they be notified is imperative. In the case at Furman University, where we have a 4-year residential requirement, and so all students are living here, having the ability to be able to provide quarantine and isolation spaces for students who may have measles or may have been connected to them isn't something that we have available. And so working with all of our students and their families to make sure that they understand what that they need to leave, and understanding what their family plan is for that is paramount with us. And then additionally, understanding at what point will we initiate our response? Is it when we're notified, or is it when we receive documentation of a diagnosis? Jeff?
Yeah, thanks. Thanks, Ron, and thanks to my colleagues. Thanks to all of you for joining in. Yeah, Jeff Novak here at UW-Madison, and I just a little background. We had one confirmed case, was an off-campus graduate student. To all of our housing colleagues that are listening, I know the wonderful things you do and your teams do, but the notion across, I know collegiate housing is that residence halls are the cesspools of college student living, and the focus is always on the residence halls, but we know all the wonderful things you do. I think important is, yes, who's controlling the info and who is it coming from? Here on our campus, University Health Services is the lead group, working with our public health officials and really it's the public health officials giving so much of the guidance, working with our strategic communication partners and who's then controlling the messages, the information flow. There's a tendency sometimes for those of us in housing, we want to get on it so much faster than others are working, and the speed to which they are sending messages out to our students. I think just a little background, and as we go forward with regards to our campus, we don't have a vaccination requirement, nor a requirement even at this time that we had this one case to share information on your vaccination status. So that was really critical in these instances. Then one case, anyone who has nothing on file must be treated as if they are not vaccinated. Immediately, our folks were able to work with the student, identify where they had been on campus, the buildings, and then work to get notifications out to all that we could identify who were in those buildings, and then following up with those that are in residence halls. I know we're going to touch on some other questions, as we go, but just for background info, we are at 115% occupancy. Our space for isolation is extremely limited. We have 6 short stay rooms that were generally for typical roommate issues, other types of perhaps illnesses that were short term, but not really, for long-term isolation and quarantine that measles would require. So we proactively sent messaging out there. If you're not vaccinated, this was during the summertime as well, knowing what the landscape was across the nation here, that you might be forced to find your own housing and that people should have plans for that. So I think, yeah, we did form a emergency operations team that met virtually regularly. So those are important things. And I think we'll get into some of those questions perhaps regarding other more specific operational logistics.
Thank you. Anything for the panel to add before we move into some of the more specific steps? Yes, Dr. Chang.
Yes, and Linda. So for our case, and then we all learned this through COVID, I think one of our strongest partners was our local public health agencies. So they're truly the ones that are accountable for any of these communicable disease infections within the county, and we are huge partners. So similar to measles, TB spreads like crazy. So we've had a couple of active TB cases on campus, and as mentioned by my colleagues here, making sure to identify who that student was, its true diagnosis. So the clinical job kind of from us and the county confirmation. And then they'll typically give you the guidelines per county, what needs to happen as far as isolation, evaluating those that were exposed, communications appropriately, and then tracking. So working with the public health agency, I think was huge. And then isolation and quarantine, once again, COVID kind of has shown us what we have or don't have. We were very fortunate to have a group of housing units that weren't yet quite ready to be provided. So we had quite a few isolation units. Those are all gone now. And looking at what's safe, sometimes going home is safer if they can be in like a parent's basement. Sometimes it's not if they're like elderly family members and young children in that environment. So looking at that, and then, reaching out to your leadership. So our student affairs leadership, our social workers, looked into, I think we had a couple of cases where if you can find a hotel or somewhere that's compliant to allow for isolation, it's a bit of a talk that's there, finding off-campus housing, being prepared for that. Just speaking to leadership, making sure that they have a good understanding, and then identifying what you've got as a resource.
Great.
Yeah, I also add to that too, with the working with public health, we schedule quarterly get-togethers with both our state public health team and our local city public health team. It's just a Zoom call, but having that ongoing communication so we know what to expect from them. They know the capabilities that we bring to the table. It really helps set that up so we can provide kind of seamless service because we both understand what the roles are and the capabilities of each of us.
Thank you. So if we could get a little bit more granular in the housing preparation and we have a couple of questions out specifically about the HVAC and really the impact that that this disease can have in terms of isolation housing and management of student needs. So Jeff and Ron, if you could speak on that, that would be great.
Sure, I can start. Yeah, I think that's a great question, and one thing that was a new twist for us, in all of our preparation planning. I think COVID did tremendous planning for housing programs across the country, and in one breath put us in such a better position. The contagiousness of measles is the much larger impact here than some of the responses is so very similar to how we reacted initially. We know much more about COVID now, but yes, up until that time, and environmental health and safety on many of your campuses plays a big role in the response here. We then learned we needed to have our rooms negatively pressurized, or again, we knew about the shared airspace and any flow back and forth, and our rooms all covered that aspect. Negative pressurized, meaning if they opened their door to the hallway, would the air remain in, was something new brought up during this. And 2 of our 6 rooms were not negatively pressurized, so took those off. So that's a big thing to certainly be looking out at. We have 9,000 in undergraduate space, all traditional double room style for 98% of our beds. So really common bathrooms. Even some of our short stay rooms don't have contained bathrooms. What's someone in quarantine versus isolation? Different campuses might have different philosophies over those, and then using that shared space. So, with respect to that question on shared air, definitely something to be talking to your campus partners about, and getting an understanding of what that is. I think in general, isolation, quarantine, knowing right now what is your campus philosophy and expectation, it's easy for us to say, yes, we have none. But when that parent or family or administrator is saying that's not acceptable, is that really going to be what you'll do in the immediacy of an event? So having that all, worked out ahead of time.
And Jeff, before we turn over to Ron for the 2 of you as well, is quarantine or isolation just for the confirmed case or anyone that may have been exposed?
We were using it well, in this case, we had the only quarantining with the one identified off-campus graduate students. So it was for quarantining of residence hall students only. I think that's something, again, to work up and have an understanding on your campus. Are you expected to house off-campus students if you have quarantine space? Because you could quickly use that up and not have enough for your own students if that was an expectation. But it was for quarantining. The isolating, the isolating is actually a much quicker time for isolation versus the 21 or longer day period for quarantining. So, but for our isolation with utilizing common bathrooms, that was going to be a problem if we ran out of the limited spaces that we did. We wound up only quarantining 1 student here. 1 student went home. When you think about the reality of it, and I give those students a lot of credit for being honest. We didn't have vaccination records on file. There were thousands of people in these classroom buildings. We should have had thousands quarantining here on campus, we even worked with enrollment management partners. We could identify, of our residence hall students who were in that academic building, but it was a self-declaration of quarantining, not a forced, quarantine.
Yeah, similarly, we were able to work proactively with our partners from risk management, student health services, academic affairs, the registrar's office, the dean of students office to identify students who didn't have documentation of vaccination at the university, and all of them, had exemptions, and we were able to identify the folks that they would have that they would come in contact with through classes and other campus events, so that when something happened, as we did experience, we could immediately or pretty rapidly identify the folks who needed to go into quarantine. Because like or as Jeff described, we had no spaces that facility services or student health services deemed satisfied the requirements for quarantine or isolation. And so we also worked with university communication to prepare messages for students, their families, and others that really helped them understand why we would respond the way that we did, and would in the future, knock on wood. But I think I couldn't agree more. Getting the right people to the table and making sure that you're talking about this as much in advance as possible. Because when it does happen, as Jeff said, in housing, we want to move really quickly. And I think many others want to as well. But they're trying to wrap their head around impact and identifying other individuals. And so as much of that as we can prepare in advance, the quicker we're all able to move when something does develop.
Great. Okay, we're going to keep trying to answer as many of the questions that are coming in the chat. We want to cover a couple of other key areas first, and then we might end up doing a rapid fire round at the very end. For our campus health presenters, how do you balance transparency with avoiding panic? And looking at the different constituencies, students, parents, faculty, staff, and Jeff and Ron, if you've got this insight too, where has the messaging been the most challenging?
Yeah, I can start with that yeah, obviously good communication, quick communication, being first out the door with it. Our challenge is that we have a student-run newspaper, I'm sure everyone does, and there's always a reporter that knows somebody who knows somebody. And so we get the calls from the student reporter pretty quickly. And so we have a process in place. So we want to be quick to get the message out. We also look to who's the best person to deliver that message. We have a residential college system. Each residential college has its own dean. Those deans have an excellent relationship with their students. So we do a lot of messaging through the deans and the residential colleges. We'll start at the central command and push out the official language and the official leadership message, but then ask the individual groups and then customize that for their audience and for their group. So they may be getting a campus-wide email from our chief medical officer. They may also get the same message or similar from their dean of their college. They may get it from their department chair, and then the departments may get it from the facilities lead, et cetera. So we try to formulate the standardized message at the top and then push that out and have everybody share that message. If they get it more than once, that's great. Parents are a little bit different. The dean of students takes very tight control over what messaging goes to parents, and that's also coordinated by our Office of Public Affairs. So we try to get that message out quickly. We're not afraid of putting it out to a variety of audiences, but we also look at the target ownership to help send that out.
Anyone else there? Okay, then moving on, and I would we're trying to answer some of these questions by typing them into the Q&A. So if you want to see the responses, you can check there as well. As we've been talking about partnerships and working together and all the key constituency groups, have any of you experienced bottlenecks that slowed you down in your response, that would be good for our attendees to know? And was there an office that you wish you would have brought to the conversation earlier?
We we did not have human resources at our first meeting, and I wish we would have. Um, it didn't impact our decisions or our response, but I think just recognizing the impact on custodial services, and the, employees, I think it would have been best that they be there.
I wouldn't say bottleneck. I mean, obviously, as I mentioned, wanting to get communications out. We were in housing wanting to send get your vaccination records in, send it to the students and the parents if we can get that in, and because I think, if I'm not mistaken, we were at about a 20% vaccination status here on campus, and that was just a self declaration, no requirement. Um, I think many of us were speaking, as we talked nationally about the, changes in vaccination willingness. I don't know if that population has hit us yet. That's kind of within the last few years. We're talking about 18 years ago, and still perhaps higher vaccination rates. So even though we didn't have it, we felt comfortable thinking people were over 90% vaccinated, which is still, I know, not the health professional's definite requirement for herd immunity, but definitely would make numbers more manageable for knowing what our quarantine kind of exposure, I guess, no pun intended, would be in the numbers of students. So I think just some of everybody wanting their hands in the communications going out and the time that it takes for that. I think there's some things too that were, less, who's the controller of information? You'd get into some of these EOCs. I heard there was another case. What are we doing? I heard there were 5 in quarantine. Who's giving the update daily? Is that your health center director or, for campus or whoever you deem, no new cases. This is the definitive place for that information. I mean, back to your early thing, the faculty and staff question comes up. So I'm thinking more about our housing colleagues out there, what are you thinking about if staff are not required but must quarantine? How are you handling that in this post-COVID virtual world? There's a definite disparity in who can remote work and who can't. So housing programs that have frontline and hourly staff that can't remote, that is loss of salary for them if they can't come in comparatively to somebody who can remote. That can be issues I've to consider when looking at all of your
Thank you,
calls.
Jeff.
Yeah. So, one situation that I think is very important is to look at protection of personal and private health information. So through COVID, it became, we just got to share about infected individuals, right? Because we were getting dozens and then hundreds at certain points for us, right? And so what can we share with housing, and what can housing share with, others? And then we got so many calls from like families of roommates about exposed individuals. And especially when you start thinking about those that do have legitimate medical exemptions, so those that are immune compromised because of whatever their medical, their diagnosis is. So one very important point is how to communicate regarding positive patients for anything, and making sure maybe risk needs to take a look to be, how do you send information, how do you communicate to a floor about what you might need to do, your resident assistants, the custodial staff, all of that. One thing that came up during COVID, so as the medical director for the student health center, I was kind of taking the lead because we just had students, once again, kind of a trickle of exposure, then infection. And it was so new that I would go out of my way to contact each of those individuals and talk to them about plans and all this other stuff. Well, then we started having staff and faculty. And I did the first few, but then I had to pump my brakes and say, I'm student health medical director. Is it okay for me to be talking to staff and faculty about their clinical concerns and issues? And so it's bringing in occupational health and the medical direction from occupational health kind of early and clear. And it wasn't like a huge gap that we had, but we kind of had a gap here on our campus. Surprisingly, we've since remedied that by working with our medical center. So making sure kind of private health information, clear communications and appropriate communications before something kind of gets out of the bag and it gets into a bit of a mess otherwise.
Thank you. We had a question in the chat, what is the percentage chance, it's a student, but I'm going to really broaden that to staff as well, can get the measles if vaccinated?
Yeah. I can share like the vaccination coverage rates. So the numbers that are out there is that with one shot, you've got 94% protection from infection. With two shots, it bumps up to 97% protection, which is wonderful. But when I think about it, it's like, well, 97%. So what about that 3%? And that's 3% out of 100. And then you've got like thousands of cases now, or even tens of thousands of cases. That 3 out of 100 can get pretty big. And in fact, the graduate student that we saw positive had been vaccinated. So you will have breakthrough vaccine. And this is where the consistency of vaccination, there are some times where like they're without the appropriate storage of vaccinations. You may have some that were sitting out too long and you've got a whole case of vaccine that may not be effective. So coverage is pretty good. It's not great. And that's where the 95% herd immunity is, just preventing your chances of being exposed in the first place is kind of that important number. While I'm kind of on the topic, there was a question about kind of prophylaxis, and I think it was answered. But getting a vaccination after you've been exposed really does not really do too much to prevent necessarily once you've got the virus kind of infection. But then questionable vaccine status. So measles is one of the vaccines that you can do a titer. You can do a lab test to look at what your immunity kind of coverage is. And so if you're not too sure, so we actually accept a positive lab, titer for measles because it should be long lasting. And actually, that's probably more accurate than just having a record from when I was 1 year old and 4 years old that said I got a couple of shots. So it's one of those infections where if you are questioning, and then that's what, if there is a case where you've got potentially exposed individuals and you may not have record or consistent record for staff or employees, you can oftentimes do a titer, and that'll tell you about their protection.
Yeah, it's interesting you mentioned that, Albert. These are some other things. I mean, I know there's a lot of questions we're probably not going to get to, as we love to do in housing. Hopefully we'll get these questions from the central office and be able to share responses and get those back out, and happy to share any other information we can too. As we were thinking, and these are some of the questions: how are residents transported? If they're at the health center and health center saying you need to go in quarantine, what are the steps from that point? I've seen some questions about use of public transportation, how we will get there. We're set up in here in housing, others might not be. These are conversations you have where we have staff that are willing, who have been vaccinated and then fit tested to transport students in our vehicles. When you were mentioning the titer testing, I volunteered to transport as well, and I could not get my records from my home state of Maine. So I went to our health center and they did a titer test for me. And Teams messaged our health center director saying, "Can I share some HIPAA data?" And I said, "My titers came back. I'm all good, with my HIPAA data, So it is very accurate, the getting the titer test for that as well. But I think there's other things to be thinking. Custodial staff, do you inform your staff if somebody's in quarantine? That is, as Albert was talking, but if a student in a quarantine space puts in a work order and somebody's responding to that in your facilities, should they have knowledge? And those are things to discuss on your campus, or safety protocols for cleaning after different providers or your experts on your campus. Some will say after 2 hours, it's normal cleaning protocols. Some will say still higher levels. So I think you won't have one answer for each of our campuses here. That's why it's important to talk with partners. I've seen the questions on transporting to hotels and who's paying for hotels. We'll probably have varied answers across our campuses of who is, what's the expectation. If you have a vaccine requirement and they chose not to, well, I guess you have to if you have a vaccine requirement. Then there's those that cannot. So is that we will pay for those who, have an exception? Not. Those are things that would have to be discussed on your individual campuses.
And the answer to, or Jeff, I think maybe you alluded to this, that yes, I will send around the unanswered questions, and we will do to the best of our ability try to answer those, knowing that some of them are going to be very campus specific or specific to each team. But before we close out, just a couple of last things. One, we are in the throes of spring break, which means people coming and going, students, faculty, staff, everyone. So, what extra layer does that add to planning or preparation or communication gathering at this point?
I think more than anything, it should inform us that, that this has to be managed, that we can't just sit with our head in the sand and think, oh, they're gone, because the reality is they're going to come back and they will have been exposed to a number of different people and different environments, and we have to be prepared. Famously, we had a planning meeting here on the books. It had been on the books for a while to make sure that we were all on point with this topic. And our first case we became aware of that morning, about an hour and a half before that meeting. And fortunately, we already had everybody planned to be around the table. But that's how I think about these environments. We have to be aware of what may happen, what can happen, and make sure that we have a plan and that everybody who needs to be around the table is looped in and ready to activate should something come up. But to just think they're all going to come back from spring break and nothing's going to happen is, I think, naive.
I kind of liken this a little bit to my days in Florida where we were dealing with hurricanes and now the Midwest and tornadoes. And I don't know which is more desirable if you have to have one. The hurricanes, at least you have the planning time, to prepare, it's coming. And I think with this is a good example. There should be no reason, on your campuses to take the lead if you have to. You're going to be responsible, in the end, with if there's an on-campus resident, all student, that we can proactively plan being ready for that, hurricane or metaphorically to come, and that can make the difference.
Yeah, I think this is a topic that comes not just with measles, but we have like hand, foot, mouth. I'm sure you guys have heard or seen it like within your dorms, and not horrible, not on the same level, but what we thought about, well, don't we have maybe three cases, right, across a couple of areas, and rather than like saying hand, foot, mouth, it's out there, just causing this kind of fervor about what's going on, we just got back to, well, just basic prevention methods once again. So cover your cough, wash your hands, stay home if you're sick, right? So, and that will prevent like 90% of the spread of what we're seeing in these respiratory cases for sure, right? Because yeah, they're gonna go home, they're gonna have fun, they're gonna go to like wherever they go for spring break nowadays, and they're gonna come back and they're gonna be sharing everything they've got. So just the basic preventive health messages that that's kind of silly, but we kind of have to remind ourselves to send those messages, like our seasonal flu information, all this information. And there was a question that I just answered regarding how can we as health professionals and just leaders on campus emphasize this message. I think number one, just meeting like this and getting a plan in place and getting the true information. So as a pediatrician, dealing with vaccine hesitancy and with just all the garbled whatever's out there, right, is so difficult. So providing at least what you can as far as good evidence-based true information, offering opportunities to get vaccinated right on campus. And I don't know, we have insurance on our campus for our students, but if not, what are those low-cost areas or those programs? I mentioned one of the partnerships we built is working with pharmacies in our area. So we have a Kroger's and an Albertsons, and they want to give shots and they will give coupons to come buy groceries. And so we bring them on campus in the fall when we have our surge of new students that need to comply with the mandate. One of the beautiful kind of additionals is they can provide vaccines not just to our enrolled students with insurance, but to staff, to faculty, to anyone that walks into one of their pharmacies. So we emphasize it as a seasonal flu vaccine campaign, But then we say, oh, you're hitting 65. Do you need your shingles? You're hitting this. What about your adult vaccinations? What about your measles, right? Are you caught up? If you're not sure, here's a coupon for $10 if you get your measles shot. So working with partners, I think is huge. And so just kind of considering all those options that are out there.
Thank you all so much for the questions. Thank you for participating. I'm humbled by the panel of experts that we have and their knowledge, and this affirms that this indeed was a topic that we need to discuss and address and provide both of our member groups with information. If you will give me a few days, this will be we'll take the recording, put it up on our YouTube site, gather information on the outstanding questions that we did not get to, and send this out to all that registered. We do have here at ACUHO-I several events coming up over the next 6 weeks. March and April are busy months. And I know if you visit our website or ACHA website, there is a ton of good information and resources. So thank you all so much again, our panelists, and those of you that participated. This was time very well spent. So enjoy the rest of the day and the rest of your week. Take care.